lucencies, branching, tree branch-like lucencies. So this is patent air-containing bronchi within the area of consolidated lung. And this is called air bronchogram. And that is a sign of consolidation, right? So we're moving on to another. This is again right upper lobe consolidation. And we can see the branching air bronchogram here. Okay, so that was just to show you what an air bronchogram is. So now we have learned all that basic concept, how to identify alveolar pattern, interstitial pattern, silhouette sign, and we have seen air bronchogram, right? So now we're moving on to identifying consolidation. What is consolidation? It's filling up of pulmonary alveoli with material that produces a shadow on X-ray. Same thing, like an alveolar opacity that we learned earlier. Any kind of opacity, any kind of tissue or material that fills up the alveoli, displacing the air, will result in alveolar opacity, and that is called consolidation. So usually when we speak in our common discussions, when we refer to consolidation, so our brain normally thinks that about an infective consolidation or pneumonia. Okay. So, but consolidation means any of this. The pulmonary alveolar, the bat wing alveolar edema that you just now saw is actually consolidation. When there is infection, pneumonic, bacterial pneumonia, that is again consolidation. Pulmonary hemorrhage occurs, the hemorrhage goes into, the blood goes into the alveoli. That is again consolidation, right? So consolidation can be anything, right? And by looking at the pattern, by looking just at the chest X-ray, we may not be able to say the cause unless it's got a specific pattern. Like say, for example, the bat wing pulmonary edema, we know it is because of cardiac failure. And let's go to a few cases of consolidation. So this is consolidation, and this was a case of bacterial pneumonia. So you can see the alveolar pattern here. In the context of the clinical context is important here. The patient presented with acute fever, all signs of an infection, acute onset, fever, cough, hemoptysis, chest pain, and all the typical signs. And then you see this pattern, then we know it is because of an infection, right? So this is a case of, again, limited by the minor fissure. So this is again consolidation starting in the right upper lobe. And you can see the dense, bulky right hilum. So this consolidation was consequent to a mass sitting here, which is probably partly causing some obstruction to the bronchi and causing an pneumonitic changes here. Okay, so without that history, or if the hilum was not bulky, we would not be able to differentiate it from a infective consolidation. So essentially, alveolar opacity due to any cause results in consolidation. It will have a bronchogram and all other features of an alveolar opacity, right? So this is a case of pulmonary hemorrhage. Again, it has resulted in an area of consolidation. You can see the air bronchogram, right? So looking just as the chest X-ray, you cannot say the etiology or the cause. Is it infective? Is it because of any other causes like hemorrhage, or is it of a tumor? We can't say, right? Now, this is bilateral perihilar pulmonary alveolar edema pattern, okay, bat wing kind. This is more of a specific pattern, and together with the clinical features, this is a straightforward case of pulmonary alveolar edema, right? So we were looking at consolidation due to different causes. This is an infective cause. This is because of obstructive cases, the tumor causing some pneumonitic changes distal to it. Now, this is because of pulmonary hemorrhage. Now, this is pulmonary edema, right? So it will look the same, the clinical features, and certain specific characteristic chest X-ray appearance, if it's there, it is easier to identify. Otherwise, your identification will not depend on the clinical history examination and the clinical presentation. Now, looking at pneumonia. Pneumonia means we're talking about infective consolidation now, okay? So collection of fluid or pus. Is it essentially an infection of the alveoli, which will result in fluid, inflammatory cells or pus within the alveoli. So for example, here we can see that most of the right lung has consolidations, and left lung also shows patchy consolidation. You can see the fluffy cotton wool appearance, ill-defined spreading edge here. You can see the air bronchogram. All patterns of a typical consolidation is there. And we know have the clinicals. We know this is pneumonia, right? Now, this is a case of pneumonia affecting the right upper lobe. This is the same case and the left sort of mid zone. So the importance is when there is so much of a pacification happening here, we don't know if there is an underlying more sinister pathology or if a tumor is there underlying it. So we cannot just treat, and if the patient gets symptomatically better, just leave him without any follow-ups. So this is the X-ray at the admission time. So we are treating him with antibiotics, and this is the X-ray at 1 week later. Most of the consolidation has cleared, and this is about residual consolidation happening in the right lung. And then 4 weeks later, most of it has cleared. Very little patches left there. And 3 months later, it's fully resolved. Okay. So when you have a patch of consolidation, what we try to do is we treat and then we repeat the X-ray at around 6 to 8 weeks time to see if it has resolved. If it has resolved means we are happy. At that time, if it has not resolved, then you have to think again. Why has it not resolved? So was there any red flag signs? Is there any suspicious clinical features are there? And if it's not resolved means you cannot leave it at that time. You will have to follow it up closely after treatment again with another X-ray or with a CT scan, ideally, to look for is there any cause, that is a tumor or a small endobronchial lesion or something sitting there which is not allowing the infection in that particular region to resolve or not, right? So that was about pneumonia consolidation. And now we come to the last topic, which is pulmonary edema or heart failure. Okay. So this is pulmonary edema means abnormal accumulation of fluid in air spaces and interstitial spaces of the lung. We have cardiogenic causes. We have non-cardiogenic causes. Okay. So we are generally going to focus on cardiogenic pulmonary edema on this in this lesson, right? So cardiogenic pulmonary edema will have certain radiological features which we call the A, B, C, D, E, and F. Diffuse alveolar shadowing, curly B lines, C for cardiomegaly, upper lobe pulmonary venous diversion, pleural effusions, fluid in fissure, right? Now, these have got a particular order of appearance. Okay, so the patient would have a sign of heart disease, that would be cardiomegaly. And usually the first sign that you see is upper lobe pulmonary venous diversion. We will see that in the next few slides. And then we start getting the interstitial pattern of edema, and then you get the curly B lines. And then you start getting the florid alveolar pattern, that is back-wing edema. You will have pleural effusions along with it. You will have fluid in, that is pleural effusion, part of effusion, you get fluid in the horizontal fissures. Now coming to the first one, the patient already has cardiomegaly. We know the criteria for measuring heart size. It has to be a PA erect view, ideally a well-centered and a good inspiratory view. So this is first rib anterior end, second rib anterior end, third rib, fourth rib, fifth rib, sixth rib. Sixth rib intersecting the right dome diaphragm in the mid-clavicular line is the ideal inspiratory level. Okay, so this is a good X-ray for measuring heart size, and cardiac size was measured. We use the heart size, widest cardiac diameter compared to the widest inner thoracic cage diameter. All this we covered in our session 1, right? And we got the cardiothoracic ratio more than 0.5. It is more than 0.55 here. So there is cardiomegaly. If you look at the vessels here, usually the upper lobe blood vessels are less prominent than the lower lobe blood vessels. Okay, the lower lobe blood vessels are more prominent than the upper lobe blood vessels. In heart failure, what happens? The pumping in left heart failure, to be precise, the pumping of left ventricle is gradually diminishing. Left atrial pressure rises. So there is more of blood pooling in the pulmonary veins, which cannot discharge fully into the left atrium. Did you get me? Left ventricle pumping is less forceful. So left atrium is not fully emptying. That means left atrial pressure rises. In fact, that in turn affects pulmonary veins which join the left atrium. So the pulmonary veins cannot fully empty and there is more of pooling of blood in the pulmonary veins. This results in more of opening of right upper lobe or the bilateral upper lobe veins and dilation of the upper lobe veins. Okay, so this is a very subjective sign many times. And this sign you will see mostly in an erect position. And on a supine X-ray, this upper lobe diversion may not be very striking, right? So here you can see more prominent upper lobe vessels, right? And this has been compared to called as a stag's antler sign. Sometimes this is very subjective. Some people might say there is stag's antler sign. Sometimes people will say there is no upper lobe diversion. So we don't tend to attach too much of importance to this sign alone, right? When there is cardiomegaly, you are suspecting, okay, there might be a sign of cardiac failure, but we don't attach too much of importance to this. Now, the next one, now we are looking at, there is cardiomegaly, and you can see more than what you see with just the lung blood vessels. More than that is there right at the periphery. So this is interstitial thickening. So in this interstitial fluid retention within the septae, interlobular septae. So this is interstitial edema. So this is how interstitial edema looks like. There is no alveolar edema component here, right? So this is interstitial pattern, and that's what we learned so earlier. Curly B lines are these peripheral interlobular septal thickening because of fluid retention. They will appear as short, linear, horizontally placed parallel lines which are touching the far end of the chest wall or the pleura. They're touching the pleura and they're usually seen just above the costophrenic angle, right? So these have been termed curly B lines. There are curly A lines, curly C lines. Let's forget all that. Let's focus only on this pattern of interstitial thickening. Curly B lines seen in this characteristic part is a sign of fluid retention, and you see that in interstitial edema, pulmonary edema. This is the typical one you probably have seen many times, bilateral perihilar alveolar pattern of consolidation. So this is alveolar type of pulmonary edema. Okay, this is consolidation. This is alveolar pattern and not interstitial. See the ill-defined spreading edge. All the opacities have merged to form a fluffy opacity with ill-defined spreading edge. This is the alveolar pattern. Curly B line was the interstitial pattern. Okay. Again, another case of cardiogenic pulmonary edema, where you can see there is alveolar pattern, and you probably are not able to see very clearly, probably peripheral interstitial pattern as well. So again, sometimes ITU X-rays, patients admitted in the intensive care unit, when we get X-rays, it's sometimes very difficult to interpret them. First of all, the most important factor that causes difficulty is technical factors. The patient cannot take a deep breath in. We cannot center the patient. They may be rotated. Patient may be lying down or semi-recumbent. So all these factors would affect the X-ray, okay? And these patients usually have an element of cardiac failure, and they also may have some infection. So it's very difficult to interpret an ITU X-ray with all technical factors suboptimal to say this is cardiac failure, this is consolidation. There might be an element of both. So there has to be a conversation between the clinicians to see what the clinical picture is like, and then you give importance, okay, this is more likely pulmonary edema. okay? Or if the patient has suddenly presented with infective episode, you can say there probably are areas of consolidation. You can't actually say. These are the limitations that we face when we have complex x-rays, especially for ITU patients, may have multiple pathologies at the same time even, okay? This is again another case of alveolar edema, okay? You don't have any interstitial pattern here. This is alveolar edema, ill-defined spreading edema, right? Now here what we've come to the pleural effusion part. So you can see costophrenic angle is obscured here. There is a pleural effusion here. This costophrenic angle is not sharply defined, so there is a small effusion here as well. And here what you're seeing here is the encysted effusion, pleural fluid within the pleural effusion within the horizontal fissure, right? Pleural effusion within the horizontal fissure sometimes give you the appearance of a tumor. It may look like a tumor. We've seen that in our session 1 when we did pleural abnormalities. But what happens when you treat cardiac failure? In response, you take an X-ray again, cardiac failure has been treated, and this tumor would have, this lesion would have disappeared. So that's why it's also called a phantom tumor or a vanishing tumor, okay? So this is the typical appearance of encysted fluid within the fissure. So now cardiac failure, cardiogenic pulmonary edema responds very quickly. Chest X-ray changes appear very rapidly. So this is the day 1. We can see the interstitial edema all over. If treated with diuretics, and you can see the pattern is all cleared, right? So that also helps us to say that this is cardiogenic edema, okay? Alveolar bat wing edema, again, it responds quickly. The lungs clears off because the fluid is removed quickly with the treatment. So that again, whereas consolidation due to any other cause like an infection or a hemorrhage, it takes time to clear. Cardiogenic pulmonary edema immediately resolves. So that again shows that this is cardiogenic. Right? So I think that brings us back to the quiz. Maisoon, would you like mouse control?
Yes, I'll just grab that.
Okay.
All right.
Just click once and it'll move to the next slide.
Yes. Did it work?
Not actually. Yeah, we can see your mouse. Just click once. Click once. Yeah.
Yes. So the first question, we had a 45-year-old unwell patient who was febrile with a cough and hemoptysis. The abnormality in the left lung that we can see here is the left upper and mid-zone consolidation. Obviously, because the cardiac contours and the mediastinal contours are still really clear, we can't just say it's one lobe. It's located in one lobe. And then obviously there's also a small, if you can see my cursor, you can see a small consolidation on the right.
We cannot see your cursor actually. We cannot see your cursor.
Is it not moving?
Try to move it again.
I'm moving it.
We cannot. Oh yeah, and it's now it's come onto the X-ray. Yeah.
Nice. Yeah. So I'm on the right lower zone here. So you could still see a small consolidation in the right lower area here. And this is the left upper to mid zone consolidation that I was speaking about initially, that we can't say it's in one lobe only because the cardiac contours are still pretty clear. And then what is the marked radiological sign called? That is here. There's an arrow pointing to it. So this is a branching linear lucency in the center, and this is the air bronchogram. For the next question, so we want to name this abnormality. Doctor was just speaking about it now. So this is a pleural effusion in the right horizontal fissure. And this is in a case of cardiac failure. This patient also clearly has cardiomegaly. You can tell the heart is pretty enlarged. And the right costophrenic angle is blunted. It's not sharply demarcated. And you could see so for the left costophrenic angle as well. So you could say this person has bilateral pleural effusions. The third question was a 55-year-old male who presented with acute shortness of breath, orthopnea, paroxysmal nocturnal dyspnea. And looking at the chest x-ray, we could diagnose him with a pulmonary edema. We could see the bat wing sign. So there's bilateral perihilar bat wing pattern, which is characteristic of alveolar pulmonary edema, basically. Alveolar opacification and pulmonary edema. These circles here are external chest leads. They're not in the patient, they're chest leads. The last question was a 70-year-old lady on treatment for heart failure. Does this x-ray show any signs of cardiac failure? So it shows interstitial pulmonary edema because you can tell on the right-sided linear opacities. I think it's a bit harder to tell very clearly, but you can see it here for sure. This indicates interstitial pulmonary edema, right-sided linear opacities. The costophrenic angles are also not very well demarcated. You can tell on here as well. So there's a possibility of small bilateral pleural effusions. And the interstitial right linear opacities are called curly B lines.
Okay, so I think that was the last case, right? And this patient. So can I take the mouse control back?
Yes.
Did we click something else? Okay, one moment. Let me. I'm taking the mouse control back. Okay, so
yes.
let me. I'm not able to move this back. Yep. Okay, so yeah, so that was the last case. And we have the feedback form here for you to send us the feedbacks. And if you have, let me go through the 3 millimeter criteria is fine with upper lobe vein diameter. Usually the upper lobe, that is a tricky area. I don't want to focus too much on that. I don't want you to focus too much on the upper lobe venous diversion part of it. Many times subjective. And usually when there are, usually the veins are smaller in caliber than the bronchi in the upper lobes. They can become equal and then bigger, right? It's sometimes very difficult to identify that because there will be a degree of edema around it as well. So I don't want to give too much importance to that sign, which many times is subjective. And then curly B lines. There's not much of questions, I believe, in the chat. All right. Inter versus intralobular septicemia. So there is no intralobular. The secondary pulmonary lobule only has an outer, that is an interlobular. Within the lobule, we have acini and centrally the bronchi and artery. Okay. On one side is interstitial consolidation of bat wing. No. Interstitial thickening, we say consolidation for alveolar pattern. On one side is interstitial consolidation of pulmonary bat wing more than the other. So it's alveolar consolidation. Maybe I don't know which X-ray you were talking about. So that whatever we saw about the bat wing was the alveolar with ill-defined spreading edges. Okay, so it's a pulmonary. It might be more on one side. Both sides were abnormal, and on one side it was more, probably. Yep. So, okay, so that was it. I'll leave the feedback form for some more time. And then thank you very much. And then I'm just muting myself and turning my video. Thank you.